Hey everyone, and welcome to this explainer. Today, we're going to look at the human heart, but I want you to completely change how you visualize it. Seriously, forget that classic Valentine's Day shape. Instead, I want you to picture the heart as an incredibly sophisticated mechanical pump. It's essentially a high-stakes plumbing system with specific chambers, pressure valves, and really thick, muscular walls that are all designed to keep everything flowing in perfect, life-sustaining harmony. But just like any complex architectural structure, sometimes the original blueprint doesn't get executed perfectly. Okay, let's dive into this. It's an absolutely fascinating mechanical mystery. We're going to explore exactly what occurs inside the human body when a crucial piece of the heart's internal architecture simply isn't there, and how that throws the entire pressure system completely out of balance. Let's start right off with Section 1, the missing wall, which is really an architectural flaw. To understand it, we first need to look at the normal blueprint. The heart has 4 rooms. You've got your right and left atria up top, and your right and left ventricles down low. Each of these side-by-side pairs is normally completely sealed off from the other by a solid, thick wall called a septum. It's the structural divider that keeps the left and right sides totally independent of one another.
But sometimes things just don't go according to plan. A ventricular septal defect, or VSD for short, happens when that lower wall, the ventricular septum, dividing the 2 bottom chambers, fails to fully close during development. It leaves behind a literal physical gap. Basically, it's an open window between 2 rooms that should absolutely have a solid brick wall between them.
To see how this gap happens, we have to rewind a bit to fetal development. The creation of this wall is actually a brilliant 2-step process. First, a thick muscular ridge of tissue grows upward from the apex, which is the very tip of the heart. Second, it meets a thinner, membranous region coming down from the top, from areas called the endocardial cushions. When they meet and fuse, voila, 2 separate, perfectly sealed chambers. But if they fail to fuse, well, you're left with that architectural flaw we call a VSD. Now, for all the medical students and anatomy enthusiasts tuning in, location totally matters here. The majority of these VSD cases actually don't happen down in the thick muscular part at the bottom. They're caused by a defect in that thinner, membranous portion of the septum up higher. That's the most common spot where this developmental handshake just fails to happen.
Moving right along to Section 2, causes and connections. Who gets VSD? Let's shift our focus to the prevalence of this condition and the specific populations most likely to encounter this blueprint error.
Now, I know it sounds incredibly rare and frankly terrifying to have a hole in your heart, but the data tells a completely different, kind of surprising story. VSDs are actually the most common congenital defect overall among newborn babies. It is literally the #1 structural issue infants face when they enter the world. But wait, here's some incredibly reassuring news. 30 to 50%, that's the number of VSDs that will spontaneously close on their own during childhood. The body actually recognizes the flaw and literally patches its own wall as the child grows. Because of this amazing self-healing capability, these ventricular defects are actually much less common in adults than you might think. However, when they don't close, or when they appear as part of a larger syndrome, we really have to look at underlying connections. VSDs are known to be associated with conditions like fetal alcohol syndrome and Down syndrome, and this brilliantly illustrates a key rule in medicine. A structural anomaly often doesn't travel alone. VSDs are frequently associated with other cardiac deformities too, acting as just one piece of a much larger anatomical puzzle. Which brings us to Section 3, the plumbing problem. Let's talk about the left-to-right shunt. Imagine for a second that you're a drop of blood navigating this compromised plumbing system. The hole is there, right? So how exactly does it change your journey? Now, what's really interesting about this setup is the dramatic contrast in mechanical force we're looking at. The left ventricle is the absolute powerhouse of the heart. It operates under extremely high pressure because its job is to blast blood out to your entire body. The right ventricle, on the other hand, operates under much lower pressure because it only has to gently push blood right next door into your lungs. And fluid dynamics tells us that liquids are basically lazy. They'll always follow the path of least resistance. So when freshly oxygenated blood returns from the lungs to that high-pressure left ventricle, it suddenly has a choice. It can fight the resistance of being pumped to the whole body, or it can easily slip through that open gap into the low-pressure right ventricle. And guess what? A lot of it chooses the easy route. This establishes a left-to-right shunt, where oxygen-rich blood takes an unauthorized extra trip right back to the lungs. So let's see how this chemical signature builds mechanically.
Because you now have oxygenated blood sneaking over to the deoxygenated side, it creates a very distinct chemical footprint. If doctors measure it, they'll find an abnormal, increased oxygen saturation in the right ventricle and the pulmonary artery, places where oxygen levels should normally be quite low.
And there's an acoustic footprint to this extra trip, too. All that blood squeezing through the narrow gap in the septum creates a lot of turbulence, kind of like a rushing river squeezing through a narrow canyon. Doctors listening with a stethoscope can actually hear this internal traffic jam. It presents as a very distinct holosystolic murmur, which is typically heard loudest right at the lower left sternal border of the patient's chest. Now we reach section 4, when pressures flip. This is the tipping point. We've talked about a small leak, but what if the gap is large? What if it goes unchecked for years? This is where the story of our blood drops journey takes a much more serious, urgent turn. If a large VSD is just left alone, the left side of the heart keeps dumping extra blood volume over to the right side, day in and day out. The right side and the lungs were simply never built to handle that kind of extreme traffic. Over time, all this extra volume physically damages the blood vessels in the lungs, leading to a dangerous condition called pulmonary hypertension. The pressure on the right side of the heart, slowly but relentlessly, begins to rise.
Which brings us to the most critical mechanical crisis in this whole explainer. The left side has essentially bullied the right side with high pressure for years. But what happens when the pressure in the lungs gets so high that the right side of the heart actually pushes back? So the crucial point is this specific, terrifying reversal of flow, a condition known as Eisenmenger syndrome. The pressure in the right ventricle climbs so incredibly high that it actually overtakes the pressure in the left ventricle. The current completely flips. The left-to-right shunt suddenly reverses into a right-to-left shunt.
This is the ultimate uh-oh moment for the body. Now completely deoxygenated blood that desperately needs to go to the lungs for air, is instead shoved through the gap into the left ventricle and blasted straight out the aorta to the rest of the body. The systemic circulation gets flooded with blood carrying zero fresh oxygen. The body's tissues are essentially being starved of the very fuel they absolutely need to survive.
Finally, let's look at section 5, spotting and fixing VSD, symptoms and solutions. When the internal plumbing goes this wrong, the outward signs become impossible to ignore. How do doctors spot this starvation? And more importantly, how do they fix the missing wall?
The physical manifestation of this oxygen starvation is a condition called cyanosis. Because the tissues aren't getting the bright red, oxygen-rich blood they need, the skin literally begins to change color. Patients will present with a bluish tint to their skin, most noticeably in areas rich in tiny blood vessels, like right around the lips or at the very tips of the fingers. It's essentially an outward alarm bell for a major internal crisis. When the symptoms become severe, or if the defect is simply too large for the body to patch on its own, medical intervention is the only way forward. The ultimate fix for this architectural flaw is surgical closure. Surgeons will literally go in and manually patch the gap in the septum, physically restoring the solid wall and forcing the blood to finally respect the heart's original intended plumbing routes.
From a microscopic gap to a dramatic reversal of pressure, the journey of a VSD shows just how incredibly dynamic our biology really is. It makes you wonder, if the heart's plumbing can adapt and sometimes dangerously overcompensate to something as major as a missing wall, what other fragile, unseen mechanical balances are quietly keeping us alive right now? Keep questioning, keep learning, and thank you so much for joining me for this explainer.